nuclei, and the subthalamic nucleus, zona incerta, and a small part of the red nucleus. One floor below, we will have the brainstem, which can be divided in an upper part, which is the mesencephalon, or also called the midbrain, where we will find the cerebral peduncle, substantia nigra, tegmentum, and tectum. And one floor below, we have the rhombencephalon, which is divided in an anterior part or ventral part, the protuberance, and a posterior part, which is composed by the cerebellum. And finally, we do have the myelencephalon, the small part of the brainstem, the medulla oblongata, which is connecting all these intracranial structures together with the spinal cord. So this division is coming from what we call the phylogenetic evolution of the central nervous system. And this is the central nervous system of a bacteria. It's very simple. We do have this intracellular and extracellular space, and in between them, in the membrane of the cell, we do have these sodium-potassium electrolytes pumps. So these pumps are regulating the different concentration of these molecules inside and outside, and these molecules are the ones which are conducting the responses. So look at this bacteria. 3,800 million years ago, it started. So these first unicellular organisms, you can see how they are touching and reacting. So it's very simple central nervous system, but very effective for them. So I'm gonna try to summarize the evolution of 3,800 million years in 30 minutes. So let's see if we can get it. So this is the evolution, one of the branches of the evolution of our central nervous system. So you can see how complex it is, and it's not like a linear evolution, but it's like a net. So different branches of the evolution have been happening in mammals, for example. But all of these nervous systems are composed by three very important parts. The neurons, we have the synapses, which are the neurons connections, and something very important, the circuit, the white matter in our case, which is a specific pattern of connections in between the different neurons. So these are the three basic components of a central nervous system. But how did it happen? How we went from a very, very, very simple central nervous system, like the ones the bacteria are having, to our very complex central nervous system. So it's because of three very important factors. Mutations, which is a key part of the evolution, the survival stress, which is something intrinsic to all the beings, and finally the environment. The environment is very important because it's regulating both the mutations and the survival stress. So let me show you how in 500 million years, the different parts of the human brain have been evolving from the first species to the brain we do have. But if we have a look now at the genomic information, we will see that the genes in which the midbrain, the forebrain, the hindbrain are regulated are all the same in our central nervous system. So it means that the small mutations have been increasing the complexity of our central nervous system. And this is a very nice graph in which you can see in the Paleolithic area how the intracranial volume of our skull has been increasing, but you can see an exponential increase of this size in a relatively short period of time. And this increasing of the size was coinciding with the greatest climate fluctuation. So this is how important are the weather fluctuations in order to help our intracranial space volume to develop. So again, the environment is affecting to the evolution. What and how do we know about the central nervous? Mainly it's coming from fossils. We can study them from molecular studies, endocasts, and the contemporary species, which are those species who were in the past already on the Earth. But probably the most important source of information to understand how this evolution has been happening is the embryology. So we can learn a lot from the embryological evolution. And this funny guy, he's Ernst Haeckel. It looks like he had a very, very interesting life. And this guy was the first who established the so-called theory of recapitulation. And he agreed that the ontogeny recapitulates phylogeny. So it means that what he was thinking is that all the embryological changes we can see in a single embryo are the signs or signatures of the phylogenetic evolution of the different species. It looks like a very, but it was very helpful, which means that if we are one of the most developed and complex beings on the earth right now, it means that all the changes on the evolution are in our embryological development. That could be very, very nice. And this is how he thinks about it. So we do have a fish with the embryo evolution. And then once a mutation happens, what Ernest Haeckel was defending, for example, when a fish became an amphibian, means that we will be able to see and to understand all the embryological changes on the fish and the fish. And then if we are more complex being, a bird or a mammal, we will be able to see all these changes on the embryological evolution of the bird. So this was very nice, but obviously this is not how it's happening, and it was pushed downwards a few years later. Why? So imagine we have two fishes embryos in the intermediate stage. So the first one is going to develop properly to a normal fish, but the second one is going to have a mutation in this intermediate stage. If the mutation is happening in the first stages of the evolution, this embryo will never give rise to a fish or any animal. It will not survive. But in the intermediate stage, we can have a mutation, and this is what happened to the fishes because they started developing their wings into some limbs. So this is how the amphibia appeared. But you can see there's a differentiation. So we are missing this part. So once we analyze the amphibian evolution, we will miss the most advanced stages of the embryo evolution of fishes. So this is what we are missing, the evolution of the most advanced stages. So indeed, this is how it's happening. And the embryo's development is only recapitulating the pre-mutational stages, increasing like this, the biodiversity. So this is how Ernest Haeckel was thinking about the evolutive process in a linear way, but this is how it's happening really. And these are the so-called cladograms. You can see it's not a linear evolution, but different trees, different branches of the same common trunk. So this different evolution is the responsible for the fantastic biodiversity we do have nowadays. So you can check the biodiversity on these graphs. This is part of the cladogram of the evolution of some mammals. So you can see that bats, dolphins, and humans are all in the same family, but our brains are different. Why are they different? Because our purpose on the earth and our needs are completely different. And our brain is adapting to the needs and to the features of the physical bodies. So let's go to our human brain. And in this coronal cut, we can see two very important parts. The cortex, which is the external surface, we will call it pallium. And pallium is a Latin word which means cover. This is why we call this pallium the external surface of the brain. Is mainly composed of gray matter. And then we do have the cerebral substance, which is inside or underlying this cortex, this pallium. And this cerebral substance can be divided in white and gray matter. The white matter is composed of association, commissural, and projection fibers, while the gray matter underlying the cortex is composed mainly of the basa ganglia and the thalamic region. Let's concentrate on how this cortex complexity has been appearing during the evolution. So let's go 500 million years back to the first fishes which were diving into the oceans. And these fishes had a very rudimentary central nervous system. It was covered, the central nervous system of these fishes, by an external surface. Salman, I don't know if someone is unmuted. It's quite uncomfortable.
I'm sorry, I'm just...
Okay, sorry. So these fishes had a very, very simple layer of one or two neurons, very simple. And this is why we call it pallium, which means very old pallium, very old external surface of the central nervous system. And mainly two functions, smell and memory, short memory, very short memory. These animals starting having mutations, and then the first amphibia appeared. And this amphibia developed some limbs so they could walk. And this amphibia developed a new layer of neurons, more complex, 3 to 4 to 5 layers of neurons. So this is the so-called archipallium, which is represented in green. But then one branch of this amphibia developed the so-called reptiles. And these reptiles left the oceans, and they can walk properly and even run to escape or to hunt. So they need a perfect coordination of their movements. This is why they developed another layer of gray matter. In this case, we called it the subpallium, because as you can see, it's in the center of their brains. It's not in the surface. And this is the rudiment of the so-called basal ganglia, the subpallium, which is the part of the brain where these movements are being coordinated. Then probably the most important change on the evolution of the central nervous system happened. And 250 million years ago, the first paleomammals started developing the so-called neopallium, which is an external surface of neurons, very complex relations in between them of 6 layers of different neurons. And this neopallium started growing and growing and covering probably the most of the external surface of the brain of these mammals. So you can see how this huge phylogenetic effort to develop this neopallium, due to the limited space of the skull, these animals had to develop this sulcogyral pattern. So this is why we have this complexity in our brains. So let's try to translate all these changes. Give me 1 second, sorry. Sorry for that. So let me try to translate all these changes to this coronal cut we had before. So we can see, we can study how these areas have been growing and developing in our brain. So let's have a look at the paleopallium signature. So mainly, these are the so-called rhinencephalic areas because of the function of smell. So we can find them at the level of the amygdala, of the limen insula, and even in some very specific parts of the insula, the most ventral ones. 1 or 2 layers of neurons. This is the so-called old brain. So these animals mainly had the brainstem and these rhinencephalic areas. Let's go to the archipallium, which appeared a little bit later. So these are the so-called limbic and paralimbic areas in our brain, which are mainly composed by the cingulate gyrus, parahippocampal gyrus, and some specific parts in the intraventricular anatomy, as the fornix, and also some paralimbic areas, which means that they are not in the midline, but in between the neocortex and the midline. And these are the areas which we can find in the anterior lobe of the insula. So you can see like the insula is having archi and palipallial areas. This is the medial view of the hemisphere where we can understand how these limbic areas are wrapping around the ventricular system and the thalamic regions. What about the subpallium, this rudiment of the basal ganglia? So it's located in the center of the brain, just parallel and lateral to the ventricular system. And finally, this mainly limbic brain of these paleomammals and reptiles gave rise to the huge neocortex, which is covering the brain of the neomammals, of the neomammal apes. And this huge development started appearing almost 50 million years ago. So you can see how the complexity and even the size of these brains has been growing during the evolution. And there was a point in which, due to the limited intracranial space, we had to develop this sulcogyral pattern. So you can see how in this graph we have more cephalic and less cephalic mammals, and fishes are reptiles and are very less cephalic animals. So you can even see how the man is located in the almost in the tip of this graph. So here we have the man, and let's have a look at and compare our brains with the rhesus monkeys. Why we have more cephalic? Why we are more cephalic animals? We need 2 very important things. First of all, we have added, in mammals, have added to our functions the internal temperature regulation, and it means that our brain must be ready to adapt to that change on the evolution. And finally, we are depending on non-acquired process. So we have more instincts. We have to analyze things and to think about why to survive and how to survive. And this is a big difference with fishes. Fishes have a very short memory, as we said before, so their reactions are very fast. They just react to fear and danger. So that's a very important difference in between us. But let's concentrate on the chimpanzees and human brains. You can see that the shape looks like the same, but the volume and the number of neurons is completely different. And you can see how the brainstem and cerebellum of chimpanzees is very similar in size to our brain, but the prosencephalum, the telencephalic vesicles, is much bigger in our case. Why is it happening? So it has been very, very deeply studied, and the answer is not clear. There are many, many clues about it, but we don't have a fixed answer. But this is something very important, and I call it when bigger is better. Let's see if that's true. So let's have a look at these skulls that we have been studying, and you can see how these monkeys had a disproportion in between the shape of the anterior aspect, the masticatory part of their skulls related to the intracranial volume. And this is completely opposite in our skull. We have a huge intracranial space, and the masticatory apparatus is much smaller. You can see this a disproportion in between us. Why is it happening? If we think about these mammals, the chimpanzees and the gorillas, they are almost all the time masticating. They are using their masticatory apparatus a lot. And 2.5 or 2.4 million years ago, we had this mutation on this MY16 protein, mainly located in the masticatory muscles. So probably we lost that protein, and that was actually good, because we started developing other ways of feeding ourselves. So we needed something different. So we lost the strength on this masticatory apparatus, and these huge muscles on these chimpanzees and gorillas are pushing the sutures. So the sutures, the cranial sutures, are being closed much sooner than in our case. So this is why their intracranial space is much smaller than ours. And this is also important not only for that, but also to develop a complex voice apparatus. So we have two very important differences. And let's have a look at this graph, and you can see how the intracranial space and the volume of our brains has been growing exponentially in the last year, thousands of years. So we can see how the Homo erectus and Homo sapiens, our volume is much bigger. Why? Because we developed hunting, harvest, and cooking features. So we can hunt, we can harvest, and we can cook. So we don't need to stay all the day masticating. So this is a big difference also in between them and us. What's special about this neopallium? We have said that it's covering 80–90% of the external surface of our brain. And why the volume of the brain is growing? Is it growing because of the neurons, or is it growing because of the white matter? So it looks like that the real effort to grow is not because of the neurons, of the cortex, of the gray matter, but because of the different connections our brain has been creating during thousands and millions of years. So the importance of the white matter is very clear. Mainly, we do have, differently to these paleo mammals, we have association fibers, which are responsible for communication in between us, for speaking and understanding. So this is one of the most complex functions we have been developing. So let's summarize again: brainencephalic areas, archipallial areas, subpallial areas, and neocortical areas. So this is the summary of the evolution, and this is the signature that the evolution has led in between us. And this is a very interesting concept I took from Professor Balavanis and Professor Yasarhil. They divided these different phylogenetic areas in two parts. So if we trace a line in between the cingulate sulcus, superior semicircular, inferior semicircular peninsular sulcus, and the collateral sulcus, we have a kind of phylogenetic belt. So all the areas just medial to this phylogenetic belt belong to the old areas, subpallium, archipallium, palepallium, and everything lateral belongs to the neocortical one. And it's a very interesting concept as we will be highlighting, and they promote it, they are defending that tumors on both sides of this phylogenetic belt are behaving in a different way. So this was something that Professor Yasser Hill described after analyzing thousands and thousands of gliomas. So we can have a look at our MRIs of our patients and say that we have a neopallial or insular or archipallial, paleo or subpallial tumor. And that's very interesting, as I will try to prove you later on. So it's quite clear that pathology follows anatomy. So it's important to understand the sulcogyral architecture to understand where a tumor is growing and how it's growing through the white matter fibers. And this is a concept that Professor Yasser Hill introduced in 1985 about the functional units. So in order to understand how these gliomas are growing, we must understand how the sulcogyral architecture is arranged in our brains. So we have the 7 lobes concept: frontal, temporal, parietal, occipital, limbic, central, and insular. And we do have also some fixed anatomical landmarks, sulcogyral landmarks, that could help us to identify where a tumor is growing. So let me share with you the first question. I don't know if you are there, Salman, but this is the question: in which functional or gyral unit is this tumor growing? This is a 14 years old patient who came to the emergency department with some hemiparesis, and in 2 days during the study of the MRI, the patient experienced a complete hemiplegia. Where do you think this tumor is located?
Guys, please raise your hands. Somebody said A. Anybody wants to answer, just raise your hands. We'll unmute you. So we have, as always, Parvat. Let's get his opinion. Yes.
This post central.
Again?
A option. Post central A option.
Post central area. Good. Any other opinion?
Okay. Server.
Post central gyrus. Post central gyrus.
Pre-central gyrus. So this is the question. It's very difficult to say, and probably you need a sagittal slice or more cuts, but this is a capricious tumor which was growing exactly in this area. Let's go. Whenever we have a doubt, we can go to the healthy hemisphere, and this tumor was growing in between the pre and the post central. Something clear is that the middle and superior frontal gyri are pushed anteriorly. So the tumor was growing in this area here, in between the pre and the post central, in the most upper part of this region. So we can do a tractography and see how this tumor is opening the fibers like a fan. So this is the initial growth stage of gliomas, in which these tumors are growing quite cortical and in a single functional unit, like in this case. And in this moment, these tumors are just pushing the fibers. And what happened to this patient is that it bled. So the sudden increase of volume caused this hemiplegia on him. So why is this tumor growing like this? If we analyze a coronal cut of a single gyrus, of a single functional unit, we can see how we have the map of all the kind of fibers there. So in the most sulcal part of the gyrus, in the depth of the sulcus, the first layer of fibers is composed by short association fibers. Then we do have the next layer, which is mainly composed by the long association fibers. And in the center of the gyrus, we have mainly commissural and projection fibers. So this tumor was pushing these commissural and projection fibers anteriorly and posteriorly. So we do have the corticospinal tract anteriorly and the thalamocortical projections to the somatosensory area posteriorly. So this is how the tumors are behaving in the first area. So this is the post-central gyrus. I entered through the post-central gyrus. This is the depth of the central sulcus. And we were stimulating just to check where was the corticospinal tract, which was pushed anteriorly. So this is what we call a functional resection. So we checked that the depth of the central sulcus was completely negative to response, and we kept going with the resection until we found a 3 to 5 milliamps subcortical response, and that's the moment where we should stop. So this is the post-op MRI 2 years later, and you can see now much better where this tumor was growing, in between the pre and the post-central gyri. And the patient, it was very lucky. For 24 hours after that, he improved a lot, and 2 years later, he's almost doing a completely normal life. So he recovered a lot, and we know that this happens a lot with kids. So that was the luck we had in that case. But let's go to another one. This is a 31 years old lady who came in a almost comatose state to the emergency room. She was referring, the family was referring some headache in the last 3 to 4 weeks, and he came with a pupil dilated, right pupil dilated, and GCS 11. So in which of the next functional units would you most likely localize this lesion? Prabhat?
Okay.
So fusiform, midbrain, amygdala, hippocampus.
It is thalamus and midbrain.
Say again?
Thalamus and midbrain, option B.
Okay, option B. Any other idea?
Anybody else wants to take this question? Where exactly functional area, what functional area is this? Ali Ahmad is there, so let's see.
Most of the answers on chat are hippocampal formation. So
Hippocampal formation.
Yeah.
Okay, so I agree with that, but I place the thalamus and midbrain because obviously if we have a look at the flare, it looks like the midbrain is invaded and also the thalamic region, but in fact they are not invaded. This is the uncus of the temporomesial region. It was completely, and the key is in the coronal cut, it's completely pushing the brainstem and invading the interpeduncular, crural, ambience, and almost even the quadrigeminal system. But this is the uncus of the temporomesial region. So you can see how the uncus is really, really herniated here. This is why the patient was in such condition with a pupil dilated. So there are very important landmarks to identify in the coronal cut. This is the collateral sulcus, this is the parahippocampal formation, and this is the hippocampus. And if we go to this flare, we can even see the body of the hippocampus completely insufflated and also the head of the hippocampus. So this is what we call the hippocampal formation tumor. So this is an anatomical cut just to correlate both things. So you can see the collateral sulcus here, which is right here in this case. This is the parahippocampal gyrus, which is right here, and the hippocampal formation completely invaded by this tumor. So we can see even the temporal horn, which is pushed upwards, and the choroidal fissure at this level. So this is the sorry? Okay, I keep going. So more slides to see the same lesion. So you can see the midbrain is pushed, not invaded. This is the uncus of the temporal lobe. So this is how the limbic system is arranged. As we have discussed previously, it's located in the midline, and it's arranged in this kind of belt-shaped arrangement of the white matter fibers, which is completely different to the orientation of the neocortical fibers. And something important, once we have understood where the tumor is located, is to plan our surgical procedure. So in order to plan a safe anatomical resection, we have to try to identify some anatomical landmarks to plan an anatomical resection. And let me show you the anatomy of the hippocampus. This is where the tumor is growing. Body, head of the hippocampus, and this is the amygdala, which is not invaded in this case. And in between the amygdala and the hippocampus, we do have the so-called ankle recess. So any of you could tell me some landmarks that you would like to find in order to check that your resection has been complete?
So landmarks to confirm that your amygdala hippocampi is complete. Yes, Parvat, you want to say something?
Yeah, that temporal horn roof, amygdala from the roof of the temporal horn. So when we reach the temporal horn, we need that we reach the roof of.
Good. And what do we have in the roof of the temporal horn?
if you are reached the roof of the temporal horn, then we are know that we are completely resected the amygdala, completely resected the hippocampus.
Great. And what about the floor of our? You'd like to see the
So
tent?
you are reached the tentorial surface. We see the tent.
Perfect. What about the medial limit?
Medial limit, we are see the crural parigeminal system.
Perimesencephalic systems. And let's go anteriorly and posteriorly. Anteriorly, we have this area here, which is the called ankle recess. And posteriorly, we have a huge part of the ventricular system, which is the atrium. So these are all the landmarks that we want to identify during surgery. And if we get all these landmarks, it will mean that we have done a safe, complete anatomical resection. Let's have a look from below so we can see the dentate gyrus, the ankle recess, this is the amygdala, which is extraventricular, and the atrium. So these are the landmarks we want to identify. And in case we can do that, it would be very interesting and very good for the patient to preserve these fibers here, which are the optic radiations. So we want to go trans T2 or even trans T3 and running upwards later on. So once we are inside the ventricle, this is our first landmark, choroidal fissure. Posteriorly, the atrium with the choroid plexus. Medially, we do have the cisterns. Inferiorly, the tent, the free border of the tent. Here it's important to identify the oculomotor nerve. So you can see it's not invaded, it's surrounded, but not invaded by the tumor. So this was not very microsurgical maneuver, but once we dissect it, we can take it out. And this is P1, P2, PCOM, interpeduncular system, the last part of the uncus. So if we see this anatomy and we have identified all these landmarks, free border of the tent, choroidal fissure with the choroidal artery. We were discussing about this artery before with Hassan. And here we have P1, P2, a very thin PCOM. This is the basilar. This is the superior cerebellar artery. And this is the third nerve, which was completely compressed by the tumor. And the cisterns. Interpeduncular is the crural at the beginning of ambient cisterns around the midbrain. So this is how we can identify our intraop landmarks in order to perform what we call an anatomic resection of this low-grade glioma. Okay, go to intermediate growth stage. If we are not able to identify, because of the location, a tumor before the intermediate growing stage, so these tumors will be able to grow through the fibers. So imagine we have a glioma growing in this superior frontal gyrus, and then because the patient is asymptomatic, this glioma with years will start growing through the long, short association fibers and even crossing the midline to the commissural and going to the ventricle through the projection fibers. So this is how these tumors are growing. So to identify where the tumor is located, how we can approach it, we can try to identify the functional unit in which it was growing at the beginning, and you can find all these pictures and all these concepts in Jasakil books, and how the tumor is growing through these fibers. So let's have a look at this one 57 years old lady who came with seizures and some personality disturbances. So have a look at that MRI, and then let's try to answer in which of the next lobes would you most likely localize this lesion? Frontal, temporal, insular, or mesiotemporal?
Please raise your hands.
Rabat. That's good.
It is missing.
Oh.
Say again.
Hello.
Hello?
Yes.
It is mesiotemporal.
I cannot understand properly. Sorry, Salman.
He said mesiotemporal.
Mesiotemporal.
Let's see, Majapin, what do you think?
Sir, it's mesiotemporal lobe. D.
Mesiotemporal there as well.
Okay, good. Something else? Any other opinion?
Any other opinion, please?
You can see the tumor going on the other part of the Sylvian fissure.
So it means it's a tumor.
Insular tumor.
Insular tumor.
Yes.
So the insular It's completely invaded by the tumor, but also the temporal lobe, but also the temporomesial lobe, and also the fronto-orbital gyri of the frontal lobe. So all the answers are correct. All the answers are correct. So it's an operculo-insular glioma. And there is a tract, a white matter tract, which is joining the fronto-orbitary gyri and the temporomesial regions. Which one? It's the arcuate, corticospinal, uncinate, or cingulate. This tract, which is joining fronto-orbitary areas, which are paleopallial, with the temporomesial areas, which are archipaleopallial.
Uncinate fascicle.
It's the uncinate fascicle.
Uncinate fascicle.
Yes. If we do this white matter dissection, we will have Yusuf next Thursday showing us how this uncinate fascicle is joining this fronto-orbitary with these temporomesial regions. This is mainly a renencephalic region, a paleopallial area. So this tumor is taking advantage of this uncinate fascicle to invade these areas. Prabhat wants to say something. Okay, so you see the insular lobe has three different origins. So three different parts of the insula: paleopallial, archipallial, and neopallial. So that's an important concept. And if we identify them, we can even classify tumors on a different way. So this is how we approach this glioma, low-grade glioma. We wanted to do a transopercular approach. So this is the insula. This is the insula with the MCA. That's the ancus. So once we remove the ancus, we see P1, P2, and the third nerve, same anatomy than before. So the temporal lobectomy is performed. This is the insular lobe, which is covered. The arteries there are covered by arachnoid. So that's a subpial resection. And then we enter through the pars orbitalis to remove the fronto-orbital component of this tumor. And we are identifying gyrus rectus, both A2s in the midline. So it means that we have reached our anatomical limit on that area. And then we want to communicate both transopercular approaches. But at this moment, our neurophysiologist told us that the patient was having a progressive loss of strength in the contralateral, in the left superior limb. So what could happen? What could we have damaged on this case?
Any takers for this?
So we have completed the temporal lobectomy, transopercular frontal approach, and once we are going deep in the insula, in the anterior aspect, we had this neurophysiology response, diminishing of the strength, of the motor strength in the left superior limb, progressive one. What would you think about?
Any answers?
So there are very important things. There are very important things. First of all, we have to check blood pressure. Sometimes just the blood pressure could justify that. Second important thing is that we are dealing close to the internal capsule, but we were far from the internal capsule in this stage. We were quite anterior. And a very important thing that in this kind of resections, we should take into consideration is vasospasm of the MCA branches. So you can see with the injection of ICG, there is a black dot here where there is this artery. This superior trunk of the MCA was having a vasospasm. So we can try to do this kind of massage if it's working. And with nimodipine, we can massage it. And we were very lucky because the flow started appearing. So this is very important to have neurophysiology in these cases and to consider all the possible causes that could have justified this problem. It's not only why angry matter. It's also important to take into consideration the vessels. An advanced growing stage of these tumors. At this stage, this was my old garden in my house. I placed this small stick. So this tree, when it was very small, I was trying to guide it. So the tree was growing through that stick. But there was a stage, in advanced growing stage, in which the tree completely destroyed the stick. This is what's happening with high-grade gliomas. They not only use the fibers to go through them, but in the advanced stages, they destroy them. And this is why GVMs are symptomatic. They present symptoms. In some patients, the symptoms will be completely irreversible if the fibers have been destroyed. Let's go for this case. This is a 73-year-old lady who came with auditory hallucinations. And you can see that tumor located there. And I'd like to have your opinion about which functional unit you think this tumor is located in. So posterior long insular gyrus.
Transverse.
Someone says transverse gyrus. Anterior saprophyseal or you said the correct answer. It's transverse gyrus of Heschel, and the symptoms are very clear. Auditory hallucinations, which is something quite uncommon, but this patient was very special. Why is the transverse gyrus of Heschel? You can see in the sagittal that the insula is completely preserved. Even the long gyri, which are the posterior ones, the insula is pushed upwards in the coronal, and in the axial we have the key. This shape, this transverse shape, is only due to this transverse gyrus of Heschel. So you can understand, if you see the anatomy in this dissection from above, you will see how the transverse gyrus of Heschel is directed from the posterior insular point towards the surface, the lateral surface of the hemisphere. And something interesting about an anatomical landmark is that this part of the transverse gyrus of Heschel, once it reaches the lateral convexity in the superior temporal gyrus, if we have a look at the brain, this is a transverse gyrus of Heschel in which the insula is exposed, the sylvian fissure is split. But if we leave it like it is, we will have the precentral, postcentral, and subcentral gyrus kissing this part. So this is a very interesting anatomical landmark, and we did an identification of the precentral gyrus neuromonitoring. So we have the motor response here, postcentral gyrus, subcentral. So without navigation, we can identify the lateral projection of this tumor. So we can do an anatomical resection through that area, and we can even reach this posterior part of the tumor without the need of a navigation, which is very helpful, but always keep in mind these anatomical tips. I think this is the last case. So this is a curious case also, because this is a patient who was experiencing some seizures, and he's a bullfighter. This guy has no fear. He's a bullfighter, very brave, and he came with this problem. And let me ask you, where would you localize this lesion? Amygdala, head of hippocampus, midbrain, or body of hippocampus?
Amygdala.
He's a bullfighter.
Sorry, Taha, you said something? Okay, so we have Rupesh. Rupesh, yes, please.
Sir, I think it's amygdala.
Amygdala? Good. So most of you think it's amygdala, and you are right. And I was not right. When I analyzed this lesion, I was not sure, to be honest with you. I even thought that it could be the head of hippocampus. But anyway, the decision should be the same. The patient had seizures, so we did pterional craniotomy. We split anteriorly a little bit the sylvian fissure, and then we do a transplanum polare approach for these cases. So the idea is to reach the inner aspect of the temporal horn as anterior as possible, so as to avoid damaging the Meyer's loop, which is in this area. And this is the ankle recess inside the ventricle. This is the head of hippocampus, completely normal, and you can see how the tumor is in the amygdala. So you were completely right. That's the amygdala invaded by the tumor, and that's the head of the hippocampus. So we kept this Meyer's loop posteriorly. And the most...
Pablo, yes. Sorry, can you again show where the Meyer's loop would be for our friends?
Yeah.
And if you can show the scan once again. I
Sure.
also thought it was hippocampus. Can we see the temporal horn at all?
Yeah, let me try to show you. So this is the ancus in the left side, and you can see in the right side, the tumor is mainly in the anterior part of the ancus, pushing the temporal horn posteriorly. Okay. So this is the head of the hippocampus. Yep. But I thought, before going to surgery, I thought that it could be a head of hippocampus tumor, but it's pushed posteriorly. Can you see it?
Yep.
Yeah.
Is it visible here?
Yes, it is.
Okay. So, I mean, Meyer's loop, you cannot see the fibers. You only see yogurt when you are inside the brain, but your 3D orientation should be very important in this stage. So if we have opened the temporal horn from anteriorly, we will have the Meyer's loop just posteriorly and superiorly to the head of the hippocampus. So these are the fibers of Meyer's loop. So we used to cover them with a cotonoid once we have exposed them there. This is just theoretical. You see the cotonoid I'm using all the time, covering what I think that the Meyer's loop is. So this is the post-op in which you can see, now the anatomy is much more clear. That's head of hippocampus, which was pushed posteriorly in this case. So this is the anatomy we were exposing. This is the amygdala, right here where the tumor was growing, and this is Meyer's loop. And inside the ventricle, we have the temporal horn. So this is the ancus. This pyramidal shape can be divided in an anterior part, which corresponds to the amygdala, and a posterior part, which corresponds to the head of the hippocampus. And if we advance in the dissection, we can see it even more clear. Meyer's loop has been cut here, head of hippocampus, ankle recess, and the amygdala, which is extraventricular. So this is the pyramidal shape. Posterior part, head of hippocampus, anterior part is made by the amygdala. Okay, so that was all, and I just wanted to highlight again how important it is to understand sulcogyral architecture and also the white matter, because this information will give us a lot of info about how the tumors are growing and how we can respect these white matter fibers and the non-invasive cortical regions. But sometimes we have to think on the opposite. Sometimes we do have scissors, and have, the scissors, the activity is spreading through the white matter. So we want to cut that spread. And this is a case from the team from Lausanne, from Professor Roy Daniel and Julia Kosu, and they have a huge experience on epilepsy. They are doing disconnective procedures. And in these cases, it's also very important to identify and to understand this three-dimensional orientation. So this is how we can take advantage of this knowledge, deciding what kind of disconnections we want to do. And we will go through all these white matter fibers on Thursday 11. So that was all. And I just want to conclude with this slide that I really, really like about the choice of the approach for any single glioma, which should be always based on anatomy. And we have to go through to respect and to perform. So we have to go through anatomical corridors, we have to respect the surrounding structures, and we have to try to perform an atraumatic manipulation. And it's coming from neuroanatomy understanding, it's coming from understanding the tumor biology. A glioma does not behave like a meningioma or like a metastasis. And finally, it's all about approaching and positioning the patient. And something important, two important rules I took from my time in Istanbul: enter the sick functional unit, that functional unit in which you think that glioma was growing, which is usually the most cortical part of the tumor, and try to stay within the tumor as possible. So this is the last slide, and I always share this one. It's a funny one, just to relax ourselves. Let's see how the rhinencephalum and the telencephalum are working. So this fish is mainly composed of rhinencephalum. So he just wants to be fed and to escape. So he's watching some danger here, and these two huge telencephalic guys have hunted this fish, but he wants to escape. That's his way, that's his goal. So he can get it. He can even beat these two telencephalic guys. And let's see how a telencephalum is working. This guy is poor and he wants to take some money. So he entered bank and he wanted the money, so he took a gun, but his telencephalum was not working properly, but he escaped. So his rhinencephalum was working properly in that case. So that's all. I just want to remind you, to thank you again, and to remind you that we will have Dr. Yassir next Sunday and Dr. Yusuf next Thursday to help us understanding the gray and the white matter of the human brain. Thank you so much.
Can I just ask one question before you start your usual feedback session? Paolo, you talk extensively about the temporal lobe today. Uh, while resecting the medial temporal lobe, do you use the choroidal fissure as a landmark at all? Does it have any importance to you?
So whenever we want to do a lobectomy with oncologic purposes, I do have a careful look at the behavior of the glioma. Obviously, if the glioma is invading the hippocampal formation, the choroidal fissure is the key. That's the key. Because once you find that fissure, this is a real anatomical limit. The tumor cannot grow into the thalamus through it if the tumor is in the hippocampus. So that's important. Even if you cannot see that clearly in the scanner, this is going to happen because there is no connection, direct connection in between the hippocampus and the thalamus. But sometimes tumors do not grow into the hippocampus, they push it. And in those cases, obviously the choroidal fissure is important, but the important thing is to hippocampal formation. Thank you. I don't know if I answered.
Right. Thanks.
Pablo, really great presentation. I learned a lot. I'm sure everybody else did as well. I think your ability, to relate the anatomy and the developmental anatomy in particular to a way that's relevant to what we do day in and day out, I think is really great and allows us to find the importance in the developmental anatomy. The concept of the functional units that you brought out, as well as how the different tumors behave based on their different locations is really great. I've been an admirer of your work, and we graduated actually a residency in the same year in 2013. Pablo graduated from Valencia University, where he did all of his pre-medical training as well. And then after that, spent time with at Uğur Tura's hospital in Istanbul, doing neuroanatomy, where I believe you picked up these wonderful dissection techniques in the line of Rhoton and carrying on his tradition for our contemporaries, and we're benefiting tremendously from the work that you've done in that regard. Pablo's published numerous papers on these concepts, both strictly neuroanatomical and also as they pertain to our everyday practice of how to apply these neuroanatomical principles that may at first seem esoteric and complicated or overly, the minute detail, but has a way of showing how it's important in understanding this in order to take great care of patients day in and day out. With that, I've been an admirer of your work for some time, and I've watched many of your YouTube videos and other presentations that you've given. Thank you so much for such a wonderful presentation and making it relevant to what we do every day.
Thank you, Asam. Really appreciate your words coming from you. Thank you.
Sorry, I had to not introduce you properly at the beginning, but I hope that can take its place.
You went too far now.
I'll stop talking and let's take some questions from everybody. There's a lot of thanks for the great presentation. One of the key things as I scroll through this is Pablo's focus on the temporal lobe, and particularly the medial temporal lobe. And developmentally, he's given us the reasons for why that's the case. And you have the archipallium and the neopallium kind of all coming together in this one location. The medial temporal lobe anatomy is different than the rest of the brain. And I'll speak personally, this is what took me the longest to understand. A temporal lobectomy is not a straightforward operation. There's a lot of pitfalls in that operation. That's why Rhoton has an entire volume dedicated to temporal lobe specifically. I've read that numerous times. I encourage you all to do the same thing to really understand it before you try to approach this area. I think the other really important concept that Pablo brought up here is this concept of landmarks along the way. how do you know that you've completed the resection? How do you know when it's time to transition to the next point of the dissection or the resection or whatever have you? Well, it's landmarks, the same things that we use to get from point A to point B as they're driving to some place. You know, Siri's telling us, or whatever navigation system is telling us where to go, but in the OR, the navigation system is misleading after the initial cortical dissection. You cannot rely on that any longer. You need vascular anatomy, gyral anatomy, sulcal anatomy, cisternal anatomy to help you as wayfinders along the way. So this concept of setting goalposts for yourself to say, okay, I've completed the anterior section when I've reached the fissure. I've completed the superior section when I reach this, or the inferior section when I reach the tentorium, the medial resection when I see the ambient cistern and the choroidal vessels. These are key concepts that I have for every single case. And the vascular anatomy, it will have the same relationship to the gyral anatomy. And so that's very, very helpful to have these concepts as you proceed with your dissection and resection. Just scrolling through the questions. Any other questions? We can unmute you if you guys have any other questions.
Azam, there are questions on YouTube that Mehak has. Mehak, if you can read those for us, we'd be grateful, please. Or you can just put them.
Sir, there were answers on the YouTube and there were great presentation comments on the YouTube. There are no specific questions up till now.
Okay, brilliant. So we'll get Dr. Muthukumar today. So say he wants to say something. Yes, please.
That was a great presentation, Dr. Pablo. In your introductory slide, you mentioned something briefly about the relationship of the human brain development vis-a-vis the climate change. Can you elaborate on that? Climate change, evolution of, there was one slide that specifically showed where you had highlighted that a significant portion of the evolutionary change was due to climate change. I'm just interested in knowing that.
Well, thank you for that. What I wanted to highlight in the introduction, I put 3 different factors which are affected generally to the evolution of any being, which are mutations, the need for survival, which is the only intrinsic thing in our genome, need for survival. This is the so-called survival stress, and the weather is part of the let's call it external environment. So our external environment is where we are living, and this can affect the way in which we need to survive because we have to adapt to it. And on the other hand, these weather conditions can even cause mutations. So these 3 factors are related to each other. And one of the examples was this curve, this line in which I was pointing at the huge growing of the intracranial volume of the brain volume during a relatively short period of time, which is the Paleolithic. At that time, there were many climate changes which probably affected and caused some mutations, and at the same time, it forced our survival stress to adapt to those situations. So this was just an example about how these 3 factors are affecting altogether to the evolution. Thank you.
Okay.
There was another question in the chat. A couple of things. Do we have time, Salman?
Yes, we do. Okay.
So one question is regarding insular tumors and their predilection for post-operative brain swelling, particularly in young patients. With regards to how to approach these tumors and different tips in the dissection or resection of these. Pablo, do you have any comments regarding that?
Well, I didn't go too deep on that. I just wanted to introduce some concepts. We will hopefully discuss them, this concept in the next 2 parts. But generally, we can classify insular tumors on 2 different ones. The purely insular ones, which are really, really limited to the insula. Even if they are huge, you can find the limits, the peri-insular sulci. And you can see how the neocortex, the operculi, are pushed, but not invaded. These are very rare, these ones, and generally they are low-grade gliomas which are limited to the central part of the insula, mainly to the anterior lobe. But if you remember that slide in which we had the insula divided in paleo, archi, and neocortical areas, these tumors are mainly located in the archipallial region, in the central part of the insula. Then we have those tumors, which are the so-called operculo-insular. These tumors are growing not only in the insula, but also in the neocortical regions of the temporal and frontal lobes. These are the tumors which are mainly affecting to the neocortical part of the insula. And finally, the third kind of tumors are those ones which are affecting to the most ventral part of the insula at the level of the apex and mainly limen of the insula. And through the uncinate, they are invading the fronto-orbitary region and the temporomesial region. So if you have a careful look at the insular gliomas, you can classify most of these tumors on these three different parts, and approaches, in my mind, are different. So if you have a purely huge insular tumor, this tumor is going to split the sylvian fissure for you. So you just open a little bit the arachnoid, push the sylvian vein upwards or downwards, depending on the branches, and then you are inside the tumor. You don't have to do a huge splitting of fissure. So in those cases, I prefer the transsylvian approach. But those cases in which the tumor is invading the neocortical areas, you can go easily through them because you have to remove those areas, obviously. So in these cases, I do transopercular approaches, transtemporal, transfrontal, and in case you have both frontal lobe and temporal lobe invaded, you finally go subpially surrounding the MCA branches, and you finally end up in the same part, which is the insula. And those cases in which the tumor is invading fronto-orbitary gyri and temporomesial regions, I usually split the anterior aspect of the sylvian fissure and go directly through the fissure to the fronto-orbitary gyri and to the temporomesial region. And again, you do a kind of transopercular. It's not transopercular, it's transcortical, transfrontal, transtemporal, but the operculum are in the lateral aspect. But you go through the frontal and temporal lobes also in those cases. We will hopefully discuss that in the next 2 sessions. We can do that.
That's great. The other question, which I think is a really important question from Hina, was regarding how to correlate anatomy from the radiology, from MRI or CT, to the microsurgical anatomy. Any tips on this, Pablo?
Wow. I can just say that you have to do the effort. You have to invest as much time as you can before the operation to try to do that thing. And the best trick I can give you is go to the lab, work with the brains, dissect them, cut them, coronal, axial, sagittal, do white matter dissections, and the 3D understanding will come to your mind. So I can tell you what happened to me when I finished my training, training in Valencia. Whenever I had a case on MRI, I could see some things. But after 1 year in the lab and attending to Professor Turel surgeries, when I came back to Spain, even if you showed me the same cases, the same slices of the MRI, I could see completely different things. So anatomy is key, and spending some time in the lab it should be mandatory. I highly recommend that.
Yeah, I think that's great advice. Some of the learning tools, online, there's Radiopedia that can help you with identification of anatomy, but it is difficult to correlate. You first have the left-right issue to contend with. Then the strange positionings that we put patients into are not anatomical positionings. They're often rotated in oblique angles. And so it is difficult to correlate this anatomy. What I could suggest is if when you look at an MRI, when you're planning the night before, is to take Rhoton's microsurgical anatomy text that says sequential dissections of various areas and try to see if you can identify those same areas from the MRI. And to do it for every single structure it would be impossible, but to do it, pick at least 5 or 10 things each time that are new or different. The more minute the detail you get into, the deeper your understanding will be of that, and to be able to correlate this specific area, for instance, the choroidal fissure. How does that look on an MRI, and how does it look anatomically? Some of the main issues relating to medial temporal lobe anatomy is that we view it best in a coronal MRI most often. However, when we in a microsurgical viewpoint, it's often in the sagittal plane, essentially. And so trying to correlate that anatomy is difficult and best done. I think Rhoton texts are very, very helpful for that. The other thing I would say is that at the end of the procedure, everybody's in a big hurry to finish and close. This is your opportunity to look at the limits of your resection and understand different anatomical features and how they appear. Maybe that the end of the resection today will be the middle of the resection next time. So trying to take a few minutes at the end of the case to say, okay, these are the limits that I had, the goalposts I had set ahead of time, as Pablo so eloquently put it. And how does this pertain to if the tumor was a little bit deeper, a little further anterior, a little further posterior, a little further medial, etc. You can play these mental exercises to try to deepen your understanding of the microsurgical anatomy and then correlate it to the radiology. So there's a back and forth, and it takes time to develop that skill.
I think, guys, that was really brilliant. Azam, you explained everything so well. And Pablo, what a wonderful presentation, as always. I really enjoy this, and that's why I think we keep asking you to come back again and again. It's wonderful to have you.
Ultimately, the real work that Pablo has done, to explain this, I think is really key. I hope that everybody extracted everything that he had to say from it, and watch it again online, because there was a lot there, a lot of really important concepts from how to even simply approach these tumors and different concepts for superficial versus what we call superficial or deep, was very eloquently stated.
Okay, so I'd request everybody to fill the post-talk quiz so that we have all the data and we see what we get, and then we can come back to this in a couple of minutes. The other thing is, Pablo, Sunday's timing is we did not keep it 6 o'clock. We changed the time. What time is Sunday for us? We said
it's 4 o'clock for you. It's 3 hours. Yeah, 4 o'clock for you.
So it's Sunday, it's going to be 4 o'clock because Pablo wants to have lunch with his family. So it's okay, it's fine, it's all right. And on Thursday we have at 6 o'clock. So those are the two timings for Sunday, and then Thursday is going to be 6 o'clock again. Please fill the quiz so you can go back and have a look at the assessments and the answers to the questions that we had before. Mehak, are we ready to see those? I'm sorry, Azam has to go back to OR, so he's just popped out. Yes, Mehak, are we ready?
So sure, I'll just put in the screen share.
Sure. There's Akmal who wants to ask a question, so we'll just unmute Akmal. Sorry. Where are we? I think that was by mistake because he disappeared on us. Okay, let's see what you've got for our next few talks. And Server wants to say something. Yes, Server. Mehak, can you unmute Server if he wants to say something?
Hello, am I audible?
Yes, you are.
Yes. Sir, my question is for Pablo, sir. Whether animal's brain is similar to human. I have seen actually his initial slides. Suppose of goat or of other animal. How much it is similar?
Which animal? Sorry, Sarwar, I didn't get it.
Goat, sheep.
Oh, wow.
Sheep or goat?
Mutton.
I'm sorry, I cannot answer you. I'm sorry. I don't know. Sorry.
Okay.
I will research on
it. Okay, let's have a look at the answers. Can we go to the answers, please? Yeah, keep going down, just down all the way. Please go down all the way. Yeah. Go.
Okay, here we are.
Pablo, all yours.
Is that the pre or the post op?
This is the
pre-quiz.
Pre-op.
Yeah,
Yeah.
pre-quiz.
Okay, so the first question was the amygdala is a structure of neopallial origin, paleopallial, subpallial, or intraventricular located, and you were quite good. It's mainly paleopallial. It's the oldest brain we have, part of the rhinocephalic region. Very good.
Okay, next.
So which of the next structures does not belong to the diencephalon? And again, you were really good. Pineal gland is epithalamus. Subthalamic region is the most ventral part of the diencephalon. Hypothalamus, obviously, is a big part of it. And the substantia nigra, it's mainly located in the midbrain. So you were good. And which of the next statements is false about the insular lobe? So I can see some interesting findings here. So it is located deep into the Sylvian fissure. This is truth, obviously. Transverse gyrus of Heschel ends into the anterior insular point. This is false. It ends or starts, mainly ends, in the posterior insular point, which is the junction of the superior and inferior peninsular sulci. And the uncinate fascicle, as we said before, is connecting fronto-orbitary and temporomesial regions. And I cannot see the last answer into the limen. Can you show? There were only 4 answers. So the last one is not an answer. It's part of the 4th. So the false thing is the transverse gyrus of Heschel ends into the anterior insular point. It ends up in the posterior insular point.
Okay. Next, please. So is this post? No, you need to click on the response. Yes, go down.
This is post quiz.
Yes, let's go down. Go down all the way.
Okay, so the first one, paleopallial origin, you were good. Second one, the diencephalon is not composed by the substantia nigra, you were good also. And now I'm happy to see that most of you changed your mind and went to the correct answer, transverse gyrus facial. So you will hire me again, Salman, after this?
Yeah, you can see, despite that, if you see, would you like to hear the same presenter again? Everybody's saying yes.
Oh my God.
So I think, you did pretty well. If you see that your presentation was excellent or very good in majority of the cases. Okay, can we have a look at our program for next couple of days? Great. We have 2 good friends, Sanjeeva and Shan Raza. Sanjeeva is going to be talking about pterional craniotomy, simple stuff, how to do a simple, good, technically right pterional craniotomy. Whereas Shan Raza is going to be talking about infratemporal fossa surgery, mostly endoscopic. We have Vlad and Professor Juma as the moderators. And this is Friday. And this is going to be at 6 o'clock Pakistan time, which is GMT +1. Okay, and next. Okay, let me just see. I'm sorry. And then we have IFNE, WFNS endoscopy weekend update. So we have, this is the 5th one that we are doing with Professor Dopajari, and we have 3 eminent speakers in this. So we have Tanok, who's going to be talking about difficult floor penetration for ETV, Kulkarni Abaya for ETV and CPC, and then Shlomi is going to be talking about ETV in infants. Moody is one of our co-moderators for this on Saturday. So we have these, and then on Sunday, we have the second part, as we said, and it's going to be 4 o'clock Pakistan time, which is going to be 1 o'clock time for Pablo. Chandra, are you there? Would you like to say a few words before we end?
No, I think this was an excellent exposition, and really glad that Pablo is taking some time out for us, and it was really wonderful teaching. Right from the development to anatomy to radiology and then to take us through some operating videos. I think this is the best way to teach. And I really congratulate you for that.
Thank you,
I'm
Chandra.
I'm looking forward to the next two dosages. Sunday, I may have to leave a little early, but I'll be there at 4:30 Indian time.
Okay, definitely. That
Okay.
would be great. So if
Yeah.
you see, this Sunday time is 4 o'clock, please. And then on Monday, we have Liliana Angelo and Mike Steinmetz from Cleveland Clinic. Mike is going to be talking about robots and spine surgery. And Liliana Angelo, who's the neuro-oncology chief there, will be talking about management of brain mets. Wednesday, we have Franco Cervedi, who's going to be talking about management of traumatic brain injury. Actually, Tariq Khan will not be giving a talk. We are going to just honor all the speakers that have given talks in the last 34 webinars we have done, and give certificates via Franco and say a few words there for each and every one of them. So guys, looking forward to seeing this and having this talk from Franco Cervedi on Wednesday the 10th. And then obviously we have the second session, and then again, Saturday, IFNE WFNS Endoscopy Committee is going to be having an arachnoid cyst as the topic. And we have actually a WFNS Spine Committee consensus meeting on Sunday. And this consensus is on thoracic lumbar fractures. How do we treat them? And they'll be voting from the WFNS Spine Committee on different consensus in order to form guidelines. Then we have David Adelson. I think we don't need to go 10 days ahead. We can talk about it later on. So guys, it was wonderful having you all. And I'm grateful to Pablo and all our friends and all the participants for such a lively, wonderful talk. And thank you, Yusuf and Yasser, who are helping Pablo. Chandra, I'm grateful as always to you. Okay.
Bizim and Salman. Thank you.
Okay. Thank you.
Yes.
Bye-bye.
Chandra. Bye-bye, Salman. Thank you.
Bye-bye.